Hi, my name is Jessica Nishikawa. I'm going to be demonstrating a few of the basic techniques of the musculoskeletal examination. These videos are meant to supplement your learning and are not intended to be completely comprehensive or replace your readings or lectures. Hi Chris, my name is Jessica. I'm a nurse practitioner. I'm going to be performing your head-to-toe musculoskeletal examination today. I'm going to be speaking so that the cameras and the students at home can learn along with us, okay?
Okay.
All right. I'm going to start with your fingers and your wrists or your hands. Initially, when you start your musculoskeletal examination, whatever system or whatever body area you're looking at, you'll want to always begin with an inspection and observation of the joint itself and then the surrounding structures. So with her fingers and wrists, I'm going to inspect them for any nodules, any masses, any gross deformity, redness, swelling, and then palpate the distal and proximal joints for tenderness, for lumps that may indicate rheumatoid or osteoarthritis, unlikely in a young patient, but it's a good habit to get into. And then palpate the ulna and radial heads for any tenderness, warmth, swelling, and signs of inflammation. The next step is to put the joint through range of motion. The hand range of motion, the finger range of motion is really extension. Go ahead and raise your fingers to the ceiling. And flexion, put your fingers down. And then the fingers themselves can adduct and abduct. So adduction is away from the body. So you move your fingers away from midline. So spread your fingers out. That's adduction. And then adduction, you're adding to your body. So you're bringing things closer to your body. So this is the range of motion of the fingers. Flexion, extension, abduction, and adduction. Okay. The wrist then, the range of motion of the wrist is similar. Flexion and extension. And then adduction and abduction. So abduction again is away from the body. So move your wrist away from midline and then move your wrist towards midline. So the range of motion here, there isn't too many degrees of range of motion if you're measuring it, but that's the range of motion of the wrist. You would think pronation and supination, but that's actually a range of motion from the elbow. So fingers and wrists. There are a couple special tests to learn involving the hand and wrist. The first one is to palpate the anatomical snuffbox. To do this, you have the patient extend their thumb laterally away from their hand, and you see this little notch that is becomes apparent, and it's even more apparent here where the depression at the base of the thumb is. You press in there with your thumb to see if there's any pain. And pain there can indicate a navicular fracture, which is a fracture of the hand that doesn't get much blood supply. So if there's a fracture there, it's pretty slow healing and sometimes can lead to some necrosis and bone death. So you want to identify that. The other special tests involve the carpal tunnel. Carpal tunnel syndrome is a common reason people seek care for wrist pain and hand numbness. So a couple of the special tests, one is called the Tinel sign. You just slightly hyperextend the wrist and palpate or percuss lightly over that carpal tunnel, which is between kind of midline between the radial and ulnar bones. So just lightly palpate there. And pain in the median nerve distribution can indicate carpal tunnel syndrome. Another test for carpal tunnel is Salience Test, and this can be done by putting the patient's hand in prayer position, or alternatively, reverse prayer position, where your hands are down like this, and ask the patient to push your wrists together. So try to get your wrists pushed together this way, and press hard for about 30 seconds or so. And at the end of that time, any numbness, tingling, or pain in that median nerve distribution can indicate carpal tunnel syndrome. Good. The last test that I'm going to teach you for carpal tunnel syndrome is called the median compression test. You just compress that nerve, the tunnel over where that nerve sits. You compress that with your thumb for about 30 seconds and ask the patient if there's pain, numbness, tingling in their hand. And if there is in that correct distribution, then that can also indicate carpal tunnel syndrome. Finally, Finklestein's test, which is a test for decorvain's tenosynovitis. You have the patient make a fist. Go ahead and make a fist and tuck your thumb under your fist. And then I'm going to gently take her fist and extend her wrist this way. And I'm putting stress. I'm stressing this area. If there was a lot of tenderness there, then that can indicate a common tenosynovitis called decorvain's tenosynovitis. Really common with all of our graduate students who are typing and writing quite a bit. Okay. One last test is the Salience Test. And this is actually a test the vascular flow of the hand. You have the patient make a fist. Go ahead and make a fist, and then I'm going to occlude both of the arteries, the radial and the ulnar artery, and then open your fist. Go ahead and open it, and her fist is white. Her hand is white. It's sort of blanched. Now I'm going to release one side, and the hand pinks up within a couple seconds. Now I'm going to have her do it again. Go ahead and make a fist, and once again I'm going to occlude both arteries. Now open your hand. And I'm going to unocclude the other opposite side, and her hand should also pink up nicely. That is called Salience Test, and that's a common procedure you should do before you puncture the wrist to collect arterial blood gases or any sort of arterial lines. Moving on next to the elbow, again starting with inspection, inspecting the elbow for any deformities, any swelling, redness, tenderness, and then palpating the olecranon process. The olecranon process is just the tip of the elbow, and then the medial and lateral epicondyle, so lateral and medial, palpating both of those for any tenderness or pain. If there's pain or tenderness there, it can indicate some what we call golfer's or tennis elbow or medial or lateral epicondylitis. The range of motion is next, and the range of motion for the elbow is flexion and extension, so flexion and extension, and pronation and supination. Good. And that's all the range of motion for the elbow. So the elbow exam is pretty quick and easy. Those main three structures in those four range of motion. We're going to next move on to the shoulder examination. The shoulder is one of the more complex joints in the body. So again, with all systems, we're looking for we're inspecting the joint first. We're looking for any gross deformity, any redness, swelling, any anomalies. Like if her shoulder was dislocated, you would actually see it hanging down lower. And again, just as with the wrists and the hands, you're looking for symmetry from one side to the next. The next step is to palpate the area. We're going to start with the suprasternal notch and then walk our fingers laterally along the clavicle until we reach the summit of the shoulder and the little bone up at the top called the acromion. The acromion process, which is actually part of the scapula, where the scapula comes behind her back and meets up with the clavicle. Just medial to that is a little ridge where the acromioclavicular junction is, the AC joint. We call it the acromioclavicular joint. So the AC joint is just medial to that acromion. From there, if you move your hands down and slightly into this deltopectoral groove, you're going to feel the coracoid process. From the coracoid process, you move your hands just laterally to the lesser tubercle and then the greater tubercle. So those are the main structures of the shoulder that I want you to be able to identify. On Chris, they're pretty easy to identify. On someone whose landmarks aren't as easy to identify, someone who's overweight or heavily muscled, you may have a little more difficult time finding these structures. Lastly, the bicipital groove. In the bicep muscle attaches in this bicipital groove right here near the lesser tubercle here. So you want to palpate that area as well. Next step is range of motion. And again, when I'm inspecting, I would inspect this shoulder as well as this shoulder, put both shoulders through range of motion. So for the purposes of these videos, I'm just going to do one side. That way you can see one side, but you would obviously do both sides and compare and make sure that they are symmetrical. Range of motion for the shoulder. We start with flexion, forward flexion, And then extension is actually when you bring your arm behind you. Good. And then abduction and adduction is away and towards the body again. So remember, abduction is away from the body. Good. And then adduction, you're going to cross your arm in front of your body. This is also called the cross arm test. So this is actually a test for rotator cuff and some impingement syndrome. So as you're asking the patient to go through range of motion, you can be assessing some of the structures of the spine. So, of the shoulder, excuse me. So we have flexion and extension, abduction and adduction, and then internal and external rotation. So to test these, you can have the patient scratch their neck. Go ahead and scratch your neck, upper neck. Good. And then reach down behind you and try to touch your opposite scapula. Good. Those are also called the Apley scratch test. So that's another test that you can perform while the patient's going through range of motion. That test is for rotator cuff injuries as well. So that's the range of motion of the shoulder. There are a few special tests that you should know that involve the shoulder. You would do these if you suspect any shoulder injuries, or if the patient comes in complaining of shoulder pain, especially rotator cuff injuries. So the first one is that I'm going to demonstrate is called Speed's test. I'm going to have Chris put your hands in this position. Good. And I'm going to press down on your palms, and you try not to let me press down, okay? So I'm just putting pressure, and she's maintaining this position. This is stressing the bicep and that bicipital groove where the tendon is. So this would be painful if the patient has some bicipital tendonitis or even a labrum tear in the shoulder. The next technique I'm going to demonstrate is called Neer's test. So for this, I'm going to place my hand on the patient's scapula. As the arm extends, a lot of times your scapula will move along with it. So I want to isolate the shoulder and the arm. So I'm going to press down on the scapula slightly, have the patient slightly pronate her arm, and then lift it up passively. If that causes pain, then that can indicate impingement or rotator cuff disorder. The next test I'm going to demonstrate for you is called Hawking's. Again, you're going to have the patient flex the shoulder and flex the elbow. With the elbow in this position and the arm in this position, I'm going to gently over-rotate that shoulder. Do you see how that shoulder is over-rotated? And if she had a rotator cuff injury, this would be painful. The last test I'm going to show you about for the shoulder examination is the Apprehension Test. This test is done by hyperextending and gently over-rotating the shoulder. So I'm going to put the patient in kind of a baseball pitcher's throw position with the shoulder flexed and the elbow flexed. And then I'm going to slightly over-rotate and lift up the arm this way. A look of apprehension on the patient's face is a positive sign, is a positive test, and can indicate a rotator cuff injury. Another test for the shoulder is the drop arm sign. You have the patient extend their arm out to the side, and then you're going to have the patient abduct their arm, slowly abduct their arm, and go ahead and do it by yourself. So active range of motion, all the way up, and then slowly have them lower their arm. If they're unable to slowly lower their arm, so if their arm, as it's going down, suddenly drops, that can indicate a tear in the rotator cuff or a rotator cuff damage. Moving on next to the neck, so we're going to start with the spine examination. The spine exam starts with the neck. Again, inspecting and then palpating the different structures, looking for warmth, tenderness, symmetry from side to side, looking at the anterior neck, making sure that the muscles are aligned, that the trachea is midline, and then I'm going to put the neck through range of motion. So Chris, can you tuck your chin to your chest, and then look up towards the ceiling. That's extension. So we have flexion, forward flexion, chin to chest, extension when she looks up to the ceiling, and then we have cervical rotation. Go ahead and look to the right, and then look to the left. And then finally lateral bending. So try to put your ear on your shoulder and then try to touch this ear to this shoulder. That's the range of motion to the neck. Alternatively, you can have the patient do a big, large neck circle, which generally gets all of those different points. So if you forget your actual range of motion, just have the patient do a big neck circle and then flexion and extension. Moving on next to the spine, I'm going to have you stand up for me and go ahead and face right there. Good. Actually, let me get behind you. Moving on next to the spine. First, from the side angle, you should be looking that the normal curvature of the spine is there. So you're looking at the cervical spine should be slightly concave, and then the thoracic spine slightly convex, and then going down towards the lumbar, there should be a nice natural lordosis or convexity again, or excuse me, concavity again down in the lumbar spine. So it should be this S curve of the spine where it goes in, out, and then in again, and it ends down at the sacrum. Okay. I'm inspecting first, as always, inspecting the spine, looking for any gross deformities, any redness, signs of infection or trauma, and then I'm going to palpate my way, starting here at C7, which is the most prominent bony vertebra that sticks out here, and walking my fingers down one by one along her vertebra, asking if there's any tenderness all the way down. You're also feeling here for what we call a step-off sign, which is when one of the vertebrae is depressed in or sticking out. They should all be somewhat in a line with each other without having any sticking in or sticking out, what we call a step-off sign, which can indicate spondylolisthesis or slippage of the vertebra. So after I've done that, I'm going to then palpate the muscles, the paravertebral muscles, which are on either side of the spine, for any spasm, rigidity, any pain. Good. Next is the range of motion of the spine. So the spinal range of motion is forward flexion. Go ahead and flex forward for me. As she's flexing forward, you can ask your patient to try to touch their toes. I'm looking at the alignment of her spine. This is a good time to check for scoliosis, making sure that the spine from C7 down this ridge of the spine to the buttocks, to the natal cleft is in alignment, and that there's no rotation of her shoulders. Her shoulders should be even in one line. They shouldn't be like this, which can indicate a rotational deformity of the spine. So her spine looks good. Go ahead and sit up. Oh, excuse me, sorry, back down. At this time also, you can place your hands on the patient's hips and make sure that they are even. Looking here now for, this is a quick check for limb length discrepancies, making sure that there's one of her hips doesn't stick up a lot higher than the other one, which can indicate that there's a limb length discrepancy. One leg is longer than the next. Go ahead and stand up for me, and just back bend just so slightly. Good, and that's extension. Good, and then twist to one side, and then twist to the other side. There's a spinal twisting, and then again, as with the neck, lateral bending. Go ahead and bend to this side, and then bend to this side. Good, great. We're going to move on next to the hip. This is probably best done if you sit down again. So go ahead and sit. The next system or body area that we're going to examine is the hip. So if the patient had hip pain, it would be important to have her undressed so that you could actually visually see the hip and compare from side to side. Chris doesn't have any complaints about her hip today, so we're going to go through the motions and show you what to assess for. So go ahead and lay back for me. Lay down. And we're going to go and show you the range of motion of the hip. The hip flexion, forward flexion, so the hip can bend up this way. And then extension is actually when the leg goes behind you this way. If the patient's lying down, they can roll over to one side and do it, or they can be lying on their belly and lift their leg up. So I'm going to have you lie on your belly quickly. And go ahead and lift your leg up towards the sky. So that is extension. Go ahead and roll back again. Actually, you can stay like that. So flexion, extension, and then
side.
Yeah, so then we're going to adduct and abduct, and you can do this with the patient flat, but it's easier to see with her on your side. So abduct with a B, again, is away from her body, so she's going to abduct it. And then adduction is harder to see, so roll again. but this leg is going to be across her body this way. Good. The hip also has, just like the shoulder, internal and external rotation. With the knee flexed, you can check internal rotation by moving the entire knee, the entire system medially towards the body. That is adduction, and then laterally away from the body, and that is abduction. And again, you would do both sides and compare one side to the next. The next step after observation and range of motion is to palpate the area. So you palpate the hip starting at the anterior surfaces. You can feel the ASIS, or the anterior superior iliac spine, and then have the patient roll over slightly until you can feel the greater trochanter, which is the lateral most aspect of the hip, and then between the greater trochanter and the ischial tuberosity, which is the bones, what we call the butt bones, so the bones you sit on, the ischial tuberosities are right in there. Between those two structures is the sciatic notch, or the sciatic nerve, that the sciatic nerve runs through. So be a little bit careful when you are palpating this area, because people have sciatica or pain in that area, then that can be pretty uncomfortable. So greater trochanter, ischial tuberosity, and then the sciatic notch in between those areas. The SI joints, sacroiliac joints, are at the base of the spine, at the superior to the buttocks. They're the little dimples in the back that you might see in surfers or see in people who are in their bathing suits. They're pretty easy to see. There are these two little dimples right in the lower spine, and that correlates to where the SI joints are. The next test is called the straight leg raise test. This is a test that you would perform if the patient was complaining of back pain that was radiating down one leg or the next, and you were suspicious for sciatica or herniated disc. With the patient supine, you ask the patient to raise their leg as high as they can, and you can help them too. If there's pain, and there might be discomfort when the leg is extended this much, but if there's pain at any time, you know at what degree the pain occurs. If the pain occurs below about 45 degrees, then that's a positive straight leg raise test and suspicious for sciatica or herniated disc. If the pain is in the right, shooting down the right leg, you can also do the same test with the opposite leg, or the unaffected leg, and elevate the unaffected leg. If there is pain in the affected leg, when the unaffected leg is raised, then that's what we call a positive crossed straight leg raise test. Next, I'm going to move on to the knee examination. So I'm going to have Chris sit up for me and dangle your knees over to the side. I'm going to start my inspection, my assessment of Chris's knees with inspection and observation. So looking for symmetry from one knee to the next, looking for any obvious effusion, which is a swelling of the knee, looking for any redness or swelling of the knee, which could indicate infection, inflammation, or even trauma to the joint. And then I'm going to palpate the area. So I'm going to palpate the knee. It might be easier if I do this one for you guys. So the medial surfaces of the knee, where the femur comes down, there's a condyle on each side of the femur, and then the tibia and fibula have little condyles right below them. So they kind of frame the kneecap. You have the medial side and the lateral side. So you want to frame that kneecap, and then obviously the patella there in the center. Feel down that, feel the patella, feel there's a little groove underneath the patella, patellar groove, and then a little bone down distal to the patellar groove, which is the tibial tuberosity. This is also the site where people who have Osgood-Schlatter's, this will get really pronounced and be a large bump. So in your assessments, if you see someone with a really large bump here, you can probably assume or ask them if they've ever had Osgood-Schlatter's disease disorder, and they'll generally tell you yes. So the patellar is framed by the medial and lateral epicondyle of the femur, and then the condyles of the tibia and fibula here. In between the condyle and the epicondyle on each side is a meniscal groove. So you have your lateral meniscal groove right here and your medial meniscal groove on the opposite side. in that groove, in between that groove sits the meniscus of the knee, where they're kind of the shock absorbers of the knee. So if there's pain over those areas when you're palpating, it can indicate a possible meniscal tear or meniscal damage, meniscal injury. On the posterior aspect of the knee, go ahead and stand up for me real quick. There's really only one structure, and that's the fossa, fossa back here. Just want to palpate that area. You will see some effusions. If the effusion's large, it will collect in the posterior aspect here. But some people will come in complaining of a fullness or of the feeling of a ball in the back of their knee, especially when they're squatting like I am. They won't be able to squat all the way because of this structure in the back of the knee. And that's called a Baker's cyst. So if you're able to palpate a large cyst back here, then that's called a Baker's cyst. Go ahead and sit for me. The range of motion that the knee can go through is flexion and extension. So we're going to extend the knee, good, and then we're going to flex the knee back behind you, very good. And then adduction and abduction. Abduction with a B, again, is away from the body. So you're moving the foot away from the body, away from midline, and then with adduction, you're adding to the body. So you're taking the foot and you're adding it to the body. So that is adduction of the knee. There are a few special tests that involve the knee. I'm going to have Chris lay back. I'm going to show you a few of those. And I'll switch to your right knee so that the cameras can see. These, again, you would do under special circumstances. If the patient came in complaining of pain or injury to the knee and you needed to check and make sure that there was no damage. So the first one I'm going to show you is Varus and Valgus stress testing. And these are two tests that will indicate meniscal damage. So you're stressing the meniscus out on either side. So for the first one, for Varus testing, you're going to be stressing the lateral aspect. So you place your hand on the patient's knee, on the inner aspect of the knee, and then your other hand on the lateral aspect of the ankle. And with this hand, I'm going to be applying pressure medially, while with my hand that's on her knee, I'm going to be pressing laterally. So I'm really trying to stress this lateral meniscal area. So I'm pressing this way to see if that causes any discomfort or pain. If there was more give there, or if there was pain when I did that, that can indicate a lateral meniscal injury. You switch those around to test the medial meniscal. So with your right hand, in this case, since I'm right-handed and on her right side, I'm going to grab the inner aspect of her knee, while with my left hand, I'm applying pressure at the knee towards the medial meniscus. This is called Valgus pressure. So this is the Valgus stress test. So I am kind of hyper extending this medial meniscus, trying to see if there was some give or laxity there, or if there was any pain or discomfort. That's Varus and Valgus stress testing. Next, we're going to go on to some of the tests for the Acl and Pcl, which are really common injuries sustained in sports and complaints of knee pain. I'm going to start with the anterior drawer sign. I'm going to have the patient flex their knee, and then I like to kind of sit on the patient's foot slightly so that I am keeping their leg stable, so that I'm not going to move their leg. And then with the palm, with your fingers, with the pads of your fingers, you're going to place that behind the patient's leg, kind of in that fossa where you would check for a Baker's cyst, just distal to that. And then with your thumbs, you're going to place them on the condyle of the tibia and fibula, and you're going to try to slide the tibia and fibula forward towards you. So if you can see that, I'm pressing the tibia and fibula towards me, trying to slide the tibia and fibula out like a drawer. So it's called the anterior drawer sign. You're applying pressure towards yourself to try to see if there's laxity there or any pain. You would also do the opposite leg and assess for symmetry or asymmetry to see if there's more give with one or the other. Oppositely, you can apply posterior pressure to the same test, and it's called the posterior drawer sign. So with your hands in the same position, you're using the radial aspect of your thumbs and applying pressure in, while with your fingers you're sort of lifting up to get that tissue out of the way. So you're applying posterior pressure. So I'm applying force down this way to see if her knee will push in like a drawer. So that's called the posterior drawer sign, and that's a test for isolated PCL tear. Generally speaking, an isolated PCL tear isn't going to occur by itself. Usually it occurs in conjunction with an ACL tear. So these tests are generally done simultaneously: anterior drawer, posterior drawer. Another test that we're going to do for ACL injury is called the Lachman's test. It's similar to the anterior drawer sign, except for you don't have the torque of your body that you're able to apply in it. So with the leg extended, you put one hand on the proximal tibia fibula and one hand on the distal femur, and you're trying to just apply pressure to see if that tibia and fibula will if there's any laxity there, if it will give. So it's not quite as specific as the anterior and posterior drawer sign. The next test is a test for medial meniscal injuries. With the knee extended, I'm going to put valgus pressure. So with this hand, I'm pressing this way. So I'm going to hyperextend sort of this medial aspect of her knee. So I'm applying valgus pressure with that, just with my right hand cupped over her heel. I'm internally and externally rotating just gently. And then I'm going to externally rotate, apply the valgus pressure, and then extend her leg. And you can do that a couple times. So apply the pressure with your left hand. With your right hand, gently externally rotate and straighten the leg. And you're listening and feeling for any crack, snapping, and popping, or any discomfort from the patient. And that can indicate a medial meniscal injury. And you can do that, obviously, again, with both sides to compare side to side. The next two tests I'm going to show you are for knee effusion and also patellofemoral syndrome. For knee effusion, there's a couple different ways to do these, and there's a couple different tests that you can learn. The easiest one is called ballottement. You just take the patella and you're pressing down sharply and quickly to see if there's any fluid displaced laterally or medially. There's also one called balloon, which you can take your hand and sort of milk any fluid that might be in the superior pouch, milk it down to where it's on either side of the patella, and then with your other hand, press on the lateral aspect of the knee, and you should see, if there's an effusion, you should see the fluid ballooning over to the medial aspect. Alternatively, you can sharply press on there, and with your hand, with your left hand on that medial compartment, you can sometimes feel a fluid wave as it hits the other side of the hand. It's hard to demonstrate in Chris because she doesn't have any knee effusions, but many times a knee effusion is a fairly obvious symptom or a fairly obvious sign where you can look at the patient's knee and know that the patient has an effusion. So it's more a skill of observation and inspection than it is a technical skill. The last test I'm going to show you for the knee is a test for patellofemoral syndrome or costomalgia patella. I'm going to have Chris relax her leg, and you can manipulate the patella side to side. It should be freely mobile, should be able to move easily. And then take that patella and compress it against the femur. And then all you have to do is have the patient activate their quad or strengthen their quadricep muscle. And that patella should track naturally into place without any pain, any crepitus, any of that crunching sensation. Crepitus is one of the signs that whenever you put a joint through range of motion, you should be feeling for crepitus in the shoulder, in the wrist, in the elbows. And that is just a grinding or grating sensation from when the bone and the cartilage, the friction between the bone and the cartilage underneath. So you're feeling for crepitus in the knees, feeling for crepitus in all the joints. The last part of the musculoskeletal examination is the feet and the ankles. I'm going to have you go ahead and sit up for this. Bring your legs to the side. The last body system with the musculoskeletal assessment is the ankle and foot. Again, it starts with inspection, just inspecting for redness, swelling, bruising, signs of trauma or infection or inflammation, all common with the ankle and foot. Ankle sprains are very common. You might see bruising, redness, and swelling, as well as inflammatory conditions like gout, which you'll see in the MTP joint in that first great toe. You can see it at any joint, but it's really common in this first great toe of the MTP joint. Next, I'm going to just palpate. I'm going to palpate the lateral malleolus right here, the major bone that sticks out in the lateral aspect of the foot. I'm going to palpate the medial malleolus on the internal aspect of the foot, the calcaneus, which is the heel bone, and then all the metatarsals and the DIP and PIP joints of the toes. Feeling for any pain, deformity, noting the arch of her foot. If she has pes planus, where she's kind of flat-footed, that can lead to pain in the ankles, pain in the knees, and pain in the hips, so it's good to note that. Range of motion of the ankle is flexion and extension, so we have flexion and then extension, and then inversion and eversion. So this is when eversion and inversion of the ankle. So you're kind of manipulating the ankle one way and the other. Alternatively, you can have the patient do circles. So go ahead and put your leg through a big circle, and that actually gets all 4 of the different range of motion of the ankle. That concludes our examination of the musculoskeletal system.